All right. This PowerPoint, I'm about to lose it. My camera stopped working, and I forgot to share my screen, and then I got it all fixed, and then I forgot to share my screen again. But luckily I didn't get it far. That's the second time. So take 30. Hopefully this works. Thanks for sticking with me. All right, we're talking about motion restrictions. Here is our outline of what we're going to cover today. More of our outline. First, we're going to talk about what normal range of motion is and what motion restrictions are. So normal range is achieved when all the tissues in the body are functioning normally and you can get to full range of motion. Motion restrictions contribute to functional limitations, cause disability, may cause further pathologies, and in order to restore your motion, you must first understand what normal motion is, determine and assess the correct cause of this limited range of motion, and then treat the actual cause of their motion restriction. So determining what the factor is that's causing the limited range and treating that. Active range of motion is when we use our own muscles to go through the range. So the muscles contract and pull through the range. It's typically a little bit less than passive range of motion, and it can be restricted by muscle weakness, by abnormal muscle tone, by pain, by true limitations that limit both passive and active range of motion. Something that I want to explain to make sure you understand clearly is active versus passive insufficiency. So active insufficiency is when you have weakness and that's limiting your ability to move through active range of motion. So passively you have full range. Actively you're not able to reach the end range because of weakness. So in that case, the passive range of motion is more than the active range of motion, and weakness is the cause of the limitation. With passive insufficiency, this is caused by tightness. A tight muscle is limiting your ability to reach end range. It could be tight ligaments and other things as well, but typically tightness is the limitation. So both passive and active range of motion are limited with passive insufficiency. So active insufficiency is caused by weakness. Passive insufficiency is caused by tightness. Passive range of motion, an external force is moving you through the range. Typically, we are that external force. So the patient is just relaxing their muscles and we are moving them through their range. Things that could restrict passive range of motion are soft tissue shortening, edema, adhesions, mechanical blocks, a disc herniation, neural tension, or pain. And those can all limit your passive range of motion. For other limitations, so there's soft tissue distension. That is tightness of tissue that's limiting the range. So the first example is in this first picture on the slide, where the gastroc, being a two-joint muscle, if it's tight on both ends, it will limit your dorsiflexion range of motion. So if somebody has their knee straight while you're testing their dorsiflexion range of motion, most likely they'll have a little less motion than if you bend the knee and put that muscle on slack and less tight, and then test their dorsiflexion range of motion again. So that is an example of soft tissue distension. Soft tissue approximation is when the muscle belly or the muscle mass is keeping you from having more range of motion. So the biceps is a good example. So when you're going through your full elbow flexion range of motion, it's limited by that giant bulging biceps in the way. So typically with that, it has a soft infill. When you push, you can feel that it goes a little bit further because it's the muscle that is stopping you, versus with the soft tissue distension, it's typically more of a firm infill, that it's a little harder to push past. You can feel more resistance to that motion. With bone approximation, the best example of that is with your elbow extending it. There's two bones there that are blocking the movement, and it is a hard infill, a hard stop. You just can't go past it because the bones are in the way. Physiological motion, this is the motion that we see. It's also called long bone movement. So this is the motion of one body segment relative to another, but it's what we see, what we name, and the movement that we voluntarily control. So shoulder flexion, shoulder abduction, all those are physiological or long bone movements. Accessory motions, which are also called joint play, are involuntary movements that are not under active control, but they are necessary for normal active and passive motion. So some of those movements include roll, glide, and spin. Concave and convex surfaces display different patterns of these movements, but all are accessory motions. So one thing to understand is the more congruent two surfaces are, so the more they are shaped the same, so like two flat surfaces, the more glide that happens. So if I have a notebook here that's flat and an eraser that's flat, when it moves on the notebook, it's just gliding back and forth. Versus if I have two incongruent surfaces, like one that's concave and one that's convex, more roll happens than glide, okay? Because it has to kind of roll along that incongruent surface. So the more congruent they are, the more gliding that's happening. The more incongruent, the more roll that's happening. With concave surfaces, that is like a wrench. So in the example, the wrench is the concave surface and it's moving on the screw or the convex surface. So if this was the bone that I'm moving and it's moving on the convex, so the concave is moving, then all three, the physiological movement or long bone movement, the roll, and the glide are all in the same direction. That's why a wrench can successfully unscrew a screw, because it's all moving in the same direction. As you push it one way, it is unscrewing the screw that same way. So as my arm is moving superiorly, the roll and the glide are all moving superiorly. So it's all in the same direction. With a convex surface, so if this is a convex surface inside of a concave, so the convex might be like the humerus inside the glenoid fossa, then as it moves in one direction, the roll is in the same direction of the movement. It's in the same direction, but the glide is in the opposite direction, okay? So as I'm moving superiorly, I roll superiorly and glide inferiorly. That's how I stay in the middle of that joint. If I do not glide in the opposite direction, I will roll right off the joint and dislocate. So if I'm moving up and I am rolling up and I'm gliding up, I am now out of the joint and I'm dislocated. So in order to stay in the middle of that joint and have good alignment and not be impinging on something or dislocating, it has to glide in the opposite direction. So as it moves superiorly, it rolls superiorly, and it must also glide down to stay in the middle of the joint. So I like this picture of the ball rolling down the hill. As it rolls down, the man must push it up or it will roll right off the hill. So if he wants the ball to stay in the same place, he must push it the opposite way that it's rolling, or the opposite way that it's moving, in order to keep it in the same place. So with a convex structure, the glide is in the opposite direction of the roll, and the roll is in the same direction as the long bone movement. So the roll and glide are in the same direction. Roll and long bone movement are in the same direction. So whatever you see is the same as the roll in both scenarios. And then with a convex surface, the glide is in the opposite direction to keep it from rolling off the joint. Accessory motions can be either intra-articular or extra-articular, with intra-articular meaning inside the joint, so those are the motions we've talked about so far, or extra-articular meaning outside the joint, such as like your scapular mobility. Those are extra-articular, but they're still accessory motions that are involuntary. Capsular patterns of motion restrictions. So these are patterns of motion loss that are caused by shortening of the joint capsule or surrounding tissue. So typically there's a pattern where it says this movement is the most restricted, followed by these that are less restricted, and this movement that's the least restricted. And that's the capsular pattern for this joint. And then you move to a different joint, and there's a different capsular pattern. So there is a specific, unique pattern of movement or of restriction in each joint that can indicate that the capsule is tight and is part of the issue. Some of the causes of the capsule being tight could be effusion, which is joint swelling, or just regular inflammation around the joint, fibrosis, like a scar tissue buildup or any type of adhesion. And the diseases that they're most commonly associated with is degenerative joint disease, arthritis, some type of immobilization, or trauma. When you have a tight capsule, you will feel a firm end feel. So when you push, there is a firm resistance that you can feel resisting that movement, and that can tell you that it's either a tight capsule, or of course it could be some other tightness, but that's one of the main indications. The non-capsular patterns are patterns of motion loss that don't follow the capsular pattern. So some of the causes could be ligament adhesions, like a limited motion in the direction. So ligament adhesion, so like a torn ligament, and it limits the motion in the direction that stretches the adhesion. So if this is a ligament and then now it's torn apart, and I'm trying to do something where I pull in that direction, that pulling apart, well, that motion will be most limited. Whatever motion causes the ligament to be most tight will be most limited. With an internal derangement, which is just a joint injury, we're talking about like rotator cuff or meniscus, things like that, the motion is limited in the direction that compresses the fragment or compresses those tissues. So if it's a meniscus injury and straightening my knee, straightening my leg causes the most compression on that meniscus, then knee extension would probably be most limited and would be a key that there is a tear or there is an internal derangement. With an extra articular lesion, which is outside the joint, this is typically more like soft tissue, like muscle injuries. The motion is limited in the direction that stretches or compresses that tissue. So it could be that the muscle that's torn is getting too stretched, or it's getting kind of squeezed and compressed that causes that limitation. There are different types of tissues that restrict motion. So some of the contractile tissues that can restrict motion are muscle, the musculotendinous junction, the tendon, and the bone interface. This typically limits active range of motion, and it can cause pain and weakness. Versus non-contractile tissues that limit motion are skin, fascia, ligaments, bursa, and capsule. These typically limit passive range of motion the most. And I love this picture of the fascia here. It's really hard sometimes for us to picture what fascia looks like. And so I like this. It's kind of like a spider web. It connects the muscle layers to the skin layers and allows for some movement, but allows them to stay connected. If your fascia gets tight or adhered to itself, then it can also restrict your movement. With this, I wanted you all to be reminded of the difference between a ligament and a tendon. A ligament connects bone to bone, and tendon connects muscle to bone. So the way I remember is 10 is a number, and it's more than one, and it connects more than one thing. So it connects the muscle to the bone, versus ligament is not a number. It connects the same thing, and that is bone to bone. That's helpful for me. You might have another way of remembering it, but that might be helpful to you. Some of the pathologies that cause motion restrictions are soft tissue shortening. That could be caused by immobilization, like wearing a cast, or by scarring, by the fiber cross-linking, the shortening of those fibers, unable to lengthen to their normal state. And some of the causes of some of those things are spasms, muscle guarding, a muscle imbalance, like one side of the joint is weak and one side is tight. ischemic necrosis, which is cell death due to lack of oxygen, or immobilization, like wearing a cast for a long time. Spasticity could also cause some contractures if you're not stretching against it. Edema can also limit the range of motion, so intra-articular fluid, so swelling inside the joint, typically mimics the capsular pattern type of restriction. Swelling outside of the joint or extra-articular fluid is not in the capsular pattern. I have a hand here because it is important to note that even a few cc's of swelling in the hand will restrict the motion because the hand just doesn't have anywhere for the swelling to go. So even just a few cc's, a little amount of swelling in the hand limits the motion. So you must get the swelling out of the hand in order to regain motion, full motion. Here is an adhesion. It can be caused by scarring, by immobilization, by not using the area, and it kind of glues the two structures together. I think this is just a beautiful example. What I'm reminded of when I think of an adhesion is when you were little and you put the glue in between your fingers and you held it there till it dried, and then you tried to pull it apart and just came apart a little bit, but you could see those little connections between the two. And in order to return functional movement after you have adhesions, you have to break those adhesions apart. So that is a painful and a hard process to do, and you have to be really careful to only break the adhesions and not ruin any other tissues. So those can really restrict movement. A mechanical block, it could be caused by cartilage fragments that are in the joint and blocking the movement, tears in the intra-articular disc or the meniscus, osteophytes, which are bone fragments that are in the joint. Any of those can cause a mechanical block. So there is a fragment of something that is causing that block. Typically, something like that will cause a more hard infill where it's just, it blocks it and it won't move any further. Now with the cartilage, it could be more springy or kind of a area like a catch, like there's an area where you have less movement or it's harder to move and then it frees back up. That's kind of a common thing with a meniscus tear, that it blocks in mid-range versus end range. But they can also cause blocks at end range. A spinal disc herniation essentially causes movement restriction because of the pain by the nerve root being compressed. And then neural tension can cause limited range of motion. This is an abnormal response to stretch from the peripheral nervous system. So it could be that it's tethered somewhere or that it's not quite long enough, or typically that it's not gliding well within the neural sheath. So there's a sheath around a nerve that it should be able to just glide right through, but if it's pinched somewhere, if it's adhered or something, it gets stuck and causes neural tension. Weakness, pain, psychological factors, muscle tone, all of those can also cause motion restrictions. During the exam and the evaluation of motion restrictions, mobility of all the structures in the area have to be tested so you can really pinpoint what is wrong. The evaluation needs to be accurate. It should be ongoing as they're going through therapy. You're continuing to assess and evaluate and determine what's wrong. It should be quantitative and qualitative, and not just me explaining what I see, but having real concrete measurements when possible. So some of those quantitative measurements that give you numbers and are easier to compare and more reliable can be done by goniometers, which you're familiar with, inclinometers, which is this top picture, electrogoniometers, which is this bottom picture, tape measures if you're measuring length and girth, radiographs, photographs, flexometers, plumb lines. Any of those things can give you numbers to quantitatively assess range of motion and tell you if it's in normal range or not. Qualitative measures, are typically what we assess how it feels, something we could describe and say, it's a firm infill or a soft infill, or that it feels springy, or, different words that we could use to describe their movement. So you can palpate their soft tissue, determine the mobility of skin or of scars, if they're tender or not, if there's any muscle spasms, is the skin hot, which would indicate there's some edema. If there is edema and you know that, is it pitting or not, like pushing into that and seeing how long it takes to come back to its normal puckering. It's not puckering anymore. It's not indented anymore. All of those are qualitative ways that you can explain what's going on with the movement. Accessory motion testing, like joint play and getting a feel for those infills and the movement and the quality of movement are all qualitative measures as well. Infills that I just mentioned, there are hard, firm, soft, empty, spasm, springy, block, boggy, extended. There's a lot of different words people use, but the common 4 words that we use and what we find in the score builders and the textbooks are hard, firm, soft, and empty. So a hard infill is typically bone to bone, or it could be a bone fragment that's not supposed to be there, and it is just a block that you can't really move past. A firm infill is typically from either muscle blocking that movement, capsule tightness, increased tone in the muscle, hypertrophy, shortening of a ligament, something like that typically can cause a firm infill, and it feels more like you feel it stop. You can push just a tiny bit past it, but it's not going any further. A soft infill is where the tissues block the movement, like with your bicep or with your knee. If you bend your knee all the way, then your hamstring and your gastroc will block that movement. That's a soft infill. And then an empty infill basically means you didn't feel anything stop you. So it could be that you didn't get to end range. You're doing passive range of motion and they're like, and then you can't go any further because it's too painful and you're not going to put them through that. That's an empty infill. It could just be because of pain. You didn't get to go all the way to end range to see what is blocking it. Or it could be that you're at end range and you're like, it is not stopping. What do I do? And that typically indicates that there is a tear, typically a significant tear if it's really nothing is stopping you in the structures that should be stopping that movement. So typically a ligament tear, could possibly be a tendon tear, something like that. With active range of motion, you're looking at the function of the contractile structure. So you're looking at how well do they move through the range using their own muscles. You look at the quality of movement, if it's symmetric on both sides, if it feels or looks normal, restrictive, excessive, or hypermobile, and then what signs and symptoms are associated with it. Sometimes they'll say, okay, it hurts right about now, and now it feels better. We call that painful arc syndrome, and that indicates a specific type of injury in the shoulder. Or sometimes they'll say, it just feels so heavy, and that may indicate weakness, or it could indicate that something is slightly torn. With resisted muscle testing, so if you do feel like something, there is weakness, then we do those manual muscle tests to determine where the weakness is, what specific muscle is weak. And your interpretation is based on the amount of force that they can resist and the position. Of course, you're not going to resist it unless they're against gravity, and the presence of pain. So if they have pain with that, that gives you a good indication of what's going on under the tissues, under the skin. Here are some of the interpretations of your restricted muscle test. So if a person is strong and painless, typically that is normal. We are strong and we don't have pain. That's like, okay, nothing's going on. Why are you here? Strong and painful is an indication typically of a partial tear. So if I'm strong but it really hurts, then there's some fibers at the end that are getting, so if this is how it's supposed to be and it's fully intact and then it's now torn, there's less fibers and they're irritated by the injury in that area, and as you pull them apart, they are causing pain. So that's typically a partial tear. If it's weak and painless, that is an indication. Now, if it's like an older person and they're just out of shape, or haven't been using it, then that is one thing. But in somebody that would normally be strong in that area, or if they're strong on one side and the other side is very weak and painless, typically it means there's a full rupture. So as I'm pulling apart, there's nothing there to be painful anymore. It's not touching, it's not pulling, it's not, irritating the damaged tissue. The tissue is all the way apart, so as you pull it, there's nothing going on to cause pain. So it might have been painful at the moment, like when they fell, or when they cut the wrong way or something, or got tackled or whatever. But then afterwards, as they're moving it, it's like, oh, it's not really painful anymore. None of that hurts. Well, that might be because it's a full tear. Weak and painful is also a partial tear, typically a little bit more of a tear than when they're strong and painful. More fibers are typically torn, and so it's even more painful, and there's some weakness there. So those are some ideas that you can get as you're testing their motion and determining what's causing their issues. Passive range of motion, you look at the amount, and you judge the infill and decide if that infill is pathological or physiological. So is it just normal because a bone that's supposed to be there is blocking me, or is it abnormal because there's a bone fragment there that shouldn't be? Another way that we test and determine what's going on with motion restriction is by passive accessory motions. So you are, remember those accessory motions we talked about, they're inside the joint, and you're testing those surfaces to determine the extensibility. So usually if you move, so you're getting really close to the joint and doing different movements in different directions to feel which ones feel tight, and that tells you if the capsule is tight, or maybe a ligament is tight and is restricting their movement. You can also test their muscle length. So this is a test to determine if they have tight hip flexors as you bend the foot up towards their head. If their hip begins to rise up off the table, then it's because that rectus femoris is tight. Remember, it's a two-joint muscle. It passes the hip and the knee. So as you're bending the knee, it will cause the hip to bend if it's very tight. So that's one way, one of many ways that you test different muscles to determine if they are tight. This one is testing the hamstrings, a hamstring 90-90 test. And then you can also test for neural tension. You can do a passive straight leg raise, so the person's laying down on their back and you raise one leg up, and if it causes pain down that leg or down the other leg, then that can indicate either there's some neural tension or there might be a bulging disc or things like that. So there are special tests that you'll learn during PTA school that can indicate what is causing this range of motion restriction. Some of the contraindications and precautions to range of motion techniques. So contraindications, if they have a dislocation or an unhealed fracture, we don't do anything with that. We don't want to move a fracture further out of place and make it not heal right. We don't want to mess with a dislocation unless, we're able to relocate it. So we're not going to test the motion in that area. I just realized something. Whatever. I think I'm sharing the wrong screen. I thought I was sharing the other screen, but I'm sharing this split screen. So that's probably annoying. And I'm sorry, but I'm not refilming it because it's my third time refilming it because I keep sharing the wrong thing or not sharing it all. So I'm sorry. I just realized I'm sharing the wrong screen. But hey, there's a screen here. You see what's going on next. Tis what it is. Sorry, guys. Immediately after surgery or after an injury, while the tissues are still healing and still very fragile, you also don't want to do range of motion assessments and risk re-damaging, re-injuring that tissue. Some of the precautions, so you must observe caution when motion might aggravate the condition. So like if there's an infection or a hematoma, if there's been an injury, if the joints are hypermobile and you don't want to overstretch them even further. All of those are reasons that you may avoid doing range of motion assessment or techniques based on that patient. Some of the approaches to help increase motion and treat motion restrictions are stretching, so passive stretching, PNF, proprioceptive neuromuscular facilitation, which you'll learn in your fall semester in the neuro course. That is basically diagonal patterns of movement that are more functional with a very specific hand placement based on if we're trying to inhibit muscle tone, to decrease it, or facilitate it if we're wanting to work on strengthening. And then ballistic stretching, those bouncing type of movements typically used in like warm-ups and things to help elongate those muscles. Some other treatment approaches are just motion itself, active or passive motion that can limit scar tissue formation or any type of adhesion formation. So in the pictures at the top, that's passive range of motion. Bottom right, he's lifting his leg and pulling it back. That's an active assisted range of motion. So he lifted it as far as he could and then used his hand to pull it more. And then down on the bottom left is active range of motion. So those are just your different types of range of motion. Sometimes when there is motion restrictions, you need surgery to actually either remove a bony block or break up scar tissue or contractures that are not responding well. Typically, contractures don't respond very well to non-invasive treatment, so it takes a long time to reverse a contracture. So when possible, we try to avoid contractures instead. Creep is actually one of the tissue's responses to stretch. It helps you increase length with application of a fixed load over time. So it is also the ability of tissue to maintain a newly gained length after a prolonged stretch. So low magnitude loads that reach the elastic range are sustained for long periods of time. This increased connective tissue deformation allows collagen to be rearranged or modeled, water to be redistributed to surrounding tissues so that that additional length can be kept. And this is why low load prolonged stretches are key. The stress relaxation is when less and less force is required to maintain the same length over time. So as you stretch, especially with a low load prolonged stretch, again, for hours or for days, even just for minutes, it's helpful, then less and less force is required to maintain that same length. There is plastic deformation and elastic deformation. So with plastic deformation, what we're talking about is elongation that remains after the load is removed. That's what we want when we're trying to increase tissue extensibility or movement after we're done with the treatment. Elastic deformation, this is elongation that does not remain after the load is removed and it returns to its prior length. We want that when we get in these crazy yoga positions and we stand up and want to still have a hip that is maintained in its socket and doesn't dislocate because we just did some crazy position. So both are good. You want tissues to bounce back to their former state so that they maintain some stability, but you also want them to be able to elongate and hold some of that new length that you've gained so that you can get new muscle length. You can increase motion that way. So physical agents or modalities can be used to assist with other interventions, but generally on their own, if all you're doing is modalities, they're not going to increase the length very much. So you can use modalities alongside of therapeutic exercise, stretching, manual therapy, all of the things we do to increase soft tissue extensibility, decrease inflammation, break up tissue adhesions, control pain, and facilitate motion. But again, we do not use modalities on their own without any other treatment. We have a few clinical case studies to go through, and we will see you in lab and work on those.